I forget. So the recording has started. I actually remembered this time. And all right, cool. So want to go over a few announcements really quickly, and then we'll jump into the content. So just a reminder that your pre-lab will close tonight. And there's actually two pre-labs. There's a pre-lab for anatomy of the heart and a pre-lab for anatomy of blood vessels. So make sure you have those completed before they close tonight so you can get full credit. Also, there are two presentations that I created, one for the heart, one for the blood vessels, and then there are quizzes that allows you to practice the information for both of those. Okay, and yes, those presentations stay up. They never go down. They should be there always. Okay, Michelle asked that question. Also, I emailed you this morning 2 learning activities. One learning activity will cover cardiac output, which we're going to talk about today. So even though I emailed them to you this morning, they weren't designed for you to like work on this morning. They were designed for you to work on them after class today over the weekend. And then I also emailed you a learning activity for blood pressure, which we're going to cover on Monday. So you're welcome to go ahead and start working on that if you want to get ahead of me, but we won't cover that until Monday. There's been a lot of interest in the take-home exam. My plan is to have the take-home exam posted by Monday of next week, and it's going to be due May 8th, so it's going to be pushed back a week. Once I get it up, I'll talk a little bit about how you submit your take-home exam, because you can like enter everything all at once and submit it, or you should be able to enter answers a bit at a time and then save, not submit, but save, and then when you're ready to submit it, you can submit it. But I'll talk more about that once it's actually on Blackboard. So next week there will be an exam 3. It will cover the muscular system, the endocrine system, blood, and the cardiovascular system. It's going to open on Thursday at 8 a.m. It's going to close on Friday at midnight. It will be half true and false questions, half multiple choice questions. I'm going to split the exam into 2 25-question parts so that you don't, you'll take one for 25 minutes, and then if you want to take a break, then you can take the other one for 25 minutes. You basically have a minute per question. In actuality, you don't need a minute per question, especially not for true and false. So if you're a little slow at the true and false, a little slow on the multiple choice questions, you should have a little extra time that you didn't use on the true and false. You'll have 25 minutes for each. There will be one question at a time. There will be no backtracking. So once you submit an answer, you can't go back and edit that answer. Okay, so one other thing I want to point out. I also made a video that covers blood vessels, which is a topic that hopefully I'll get to today. But if I don't get to it today, then watch the video. There's a link to it on the email I sent you today. And I'll also post it on Blackboard. The reason why I went ahead and made a video is just in case I don't get to that topic today. It's not a very difficult topic, and in fact, it overlaps a lot with the presentation on blood vessels for the lab. But I just want to make sure that I'm able to cover the content that I have to get covered in Chapter 11 before our exam next week. Sometimes you can get a little bogged down in cardiac output and blood pressure, and I want to make sure there's adequate time to cover those thoroughly in class. And if I don't get to blood vessels, I can say, hey, you can just look at that online. Okay, so what we're going to do now is start where we ended on Wednesday. And we're going to continue to talk about the physiology of the heart, how the heart works. We finished talking about the coordination of the activity of the heart via the intrinsic conduction system. We talked about dysrhythmia or abnormal rhythms such as tachycardia and bradycardia. And we talked about fibrillation and AFib, VFib, and a defibrillator. And so now we're going to continue talking about more physiology of the heart, starting with the cardiac cycle. We're going to make sure you understand what systole and diastole are. We're going to explain what normal heart sounds are and what a abnormal heart sound is, which is a heart murmur. So the cardiac cycle is pretty much all of the events that occur in the heart within one complete heartbeat. So if we start with the atria contract and empty their blood into the ventricles, and then they begin to relax. The ventricles then contract and eventually relax. Contraction is referred to as systole. Relaxation is referred to as diastole. And unless you are told otherwise, systole and diastole refer to the ventricles. So if you just see the word systole, it refers to when the ventricles are contracting. If you see the word diastole or read the word diastole, it refers to when the ventricles are contracting, unless it's preceded by like atrial systole or atrial diastole, which would specifically mean contraction and relaxation of the atria respectively. Otherwise, you assume it means the ventricles. This cardiac cycle where the atria contract and relax, the ventricles contract and relax, typically covers about 0.8 seconds. So this is a figure from your book, and it basically shows you what's occurring during one cardiac cycle. So here we have the atria that are filling with blood. The valves are open because the entire heart is basically in diastole. Blood is, or relaxation, blood is moving into the atria and then into the ventricles. The ventricles are filling. As the ventricles fill, right when they're about full, the atria contract. So we have atrial systole. The ventricles are still in diastole. And when they contract, they're just moving that last bit of blood in the atria into the ventricles. The ventricles then start ventricular systole. They begin to contract because they need to move that blood through the great vessels, the pulmonary as well as the aorta. To prevent the backflow of blood into the atria, the AV valves close, the tricuspid and the mitral valve. And that ensures that pressure pushes that blood into the great vessels. After the after the blood enters the great vessels and the ventricles empty, they then begin to relax. And you have what's called the diastole of the ventricles. The great vessels, the pulmonary trunk and the aorta, are now filled with blood. And that blood would start to flow back into the ventricles were it not for the semilunar valves, which come off the sides of those vessels and they prevent the backflow of blood. And then eventually these semilunar valves opened again and we're right back at diastole, where there's blood going into the atria, which are relaxed, and into the ventricles, which are also relaxed. This is one complete cardiac cycle, and though I took about a couple of minutes to explain it, it occurs in a roughly 0.8 seconds. Let's talk about heart sounds, where everyone here has probably heard heart sounds. Either you actually have used a stethoscope, or you have heard the sounds on TV or on the internet. What are you actually hearing? Well, in normal heart sounds, you're not hearing blood flowing through the heart. You're not hearing contractions of the heart. What you're actually hearing are the closings of the AV and the SL semilunar valves. Right? When the beating of the heart is often described as a lub-dup followed by a pause. So like a lup-dup, lup-dup, lup-dup. And what you're hearing with the lup is the AV valves closing. And what you hear with the dup is the semilunar valves closing, right? So the lup is the closing of the AV valves. The dup is the closing of the semilunar valves. You're not hearing anything else normally. So if we go back to this animation that we looked at when we were looking at an EKG, right? And this time, instead of focusing on the electrical movement of electricity through the heart, let's focus on those valves. Lup, dup. Lup, dup, as those valves close. Again, a lot of people mistakenly think that when you're listening to heart sounds, you're hearing the heart contract, or you're hearing blood move through the heart. Not normal sounds. What you are hearing is simply those valves closing. Lup, dup. If you hear anything else, what you are actually hearing is a heart murmur. Abnormal sounds of the heart is what a heart murmur is. And it's typically what you're hearing is turbulent flow of blood through the heart. If the heart is operating normally, except in a very small child, you shouldn't hear blood flowing through the heart because it should be flowing in a way that it doesn't produce sound. Let me demonstrate what I mean. So there is what is called laminar flow, and then there is turbulent flow. Laminar flow, and this could refer to the flow of air as well as the flow of water. If you have a substance that is moving in pretty much parallel bands, it doesn't make much in the way of sound. Think of a deep river that you're standing beside. There are no rapids, and you don't really hear much. Contrast that with turbulent flow. If you have water or even air bouncing around, you tend to hear that. If you've ever stood beside a river where it had rapids, you hear that water hitting the rocks and running into one another. Into other water and all that kind of stuff. Turbulent flow causes sound. There should be, in normal circumstances, laminar flow of blood through the heart. And you shouldn't hear the flow of blood through the heart. If for some reason there's turbulent flow, like if the valve's not closing all the way or opening all the way, and you get turbulent flow of blood, it makes noise, and that you can hear. And those are the main causes of a heart murmur. So as I said, it is possible that you can hear the flow of blood in very young children because the walls of the heart can be quite thin. But in adults, you shouldn't hear anything but that lub-dub. If you do hear flow of blood, then probably there's some dysfunction, some abnormality with the valves. You can have situations where the valves don't open completely, called stenosed valves. And this causes a turbulent, fast flow of blood from the atria into the ventricles, or from the ventricles into the great vesicles. And you also can have incompetent valves that don't close all the way, so you get regurgitation into the atria or back down into the ventricles. And this is turbulent flow of blood, and so it makes a sound. Okay. Now, I won't be playing these for you because they won't transmit very well in our through Blackboard Collaborate. But if you are more interested in heart murmurs, there's a nice website that you can go to get more information on them. There are lots of different types of heart murmurs. Heart murmurs are quite common. I have a heart murmur. It doesn't necessarily mean that there's something that needs addressing. In other cases, it might mean that there is an intervention that is necessary. But there are so many different types of heart murmurs, and they're caused by different issues with the valves. If you're interested in more information, it's beyond the scope of this class to go any further, then you can check out this website. What I want you to understand is that a heart murmur is an abnormal sound of the heart, typically caused by some abnormality in the heart, commonly the valves, although there can be other reasons and abnormalities for them as well. Okay, any questions before moving on to talk about cardiac output? And I want to remind you that I emailed you a learning activity on cardiac output that I want you to take a look at and complete over the weekend, and then we'll go over the answers and discuss it on Monday. Any questions at this time? All righty, if there are no questions, let's move into cardiac output. We're going to first start by defining cardiac output. Then we're going to make sure that you can write the equation from cardiac output, explain the factors that affect heart rate, explain the factors that can affect stroke volume, and then explain why people who engage in aerobic exercise regularly have a lower resting heart rate than people who are more sedentary. Cardiac output is the volume of blood pumped by the left ventricle each minute. Cardiac output is the volume, typically measured in milliliters, that the left ventricle pumps every minute. Why do we care about cardiac output? Well, it's used to estimate the efficiency of the heart. It tells you, well, how much blood can the heart move every minute? How much blood flows to the tissues of the body every minute. It's a simple equation for calculating cardiac output, and you need to be familiar with this equation. In fact, what I tell students when we meet face to face is that you need to regurgitate this on an exam. You actually need to be able to write this on the exam. Now, you won't have to write this on your exams, which will be online, but I'm going to ask you questions that will require you to know this equation. So make sure that you do. I don't know how you can really understand cardiac output without knowing the equation for cardiac output. My major professor used to say, if you can't explain something mathematically, you really can't explain it. And it's a simple formula. Cardiac output, CO, equals stroke volume times heart rate. Cardiac output is the amount of blood that your left ventricle pumps per minute. That's going to be determined by, well, how much blood leaves the ventricle every time it contracts. That is what stroke volume is. The amount pumped by the ventricle per beat, or milliliters volume per beat. Heart rate, which of course is your pulse, is going to be the beats per minute. So if we multiply beats per minute times milliliters per beat, we get milliliters. So what's typical values, typical normal values? Well, normal resting values are as shown here. And when we say normal resting, this is like what you're doing now. You're not running or jogging. You are at rest. So normal values for stroke volume would be 70 milliliters per beat, and heart rate could be 75 beats per minute. And again, we understand that this differs from person to person due to age, level of conditioning, all that kind of stuff. But let's sub this into our equation. So here we have cardiac output equals stroke volume times heart rate. So stroke volume, 70 milliliters per beat times 75 beats per minute. And using what we know about math, the beats cancel out, and we are left with milliliters per minute. So a typical resting cardiac output would be 5,250 milliliters per minute, cardiac output. Now let's talk about all the different factors that can affect cardiac output. So cardiac output equals stroke volume times heart rate. Then anything that affects stroke volume and anything that affects heart rate is going to affect cardiac output. So we're going to look at different factors that affect heart rate and stroke volume. And we're going to start with heart rate first. So what are some of the factors that can affect the heart rate? Well, your autonomic nervous system, of course. Remember, your autonomic nervous system is the part of the nervous system that controls your visceral organs, those organs that you don't have direct control of. If you recall, the autonomic nervous system has two arms, the parasympathetic and the sympathetic. Sympathetic prepares your body for increased level of activity. Parasympathetic nervous system basically controls those processes that occur when you are at rest, like, or I should say that are increase in activity when you are at rest, like digestion and diuresis, etc. The parasympathetic nervous system, therefore, slows your heart rate. The sympathetic nervous system increases your heart rate. You can sort of think of them as like your brake and your gas. So, parasympathetic stimulation is going to decrease heart rate. Sympathetic stimulation is going to increase heart rate. Hormones can also increase heart rate. Your thyroid hormones increase your metabolic rate. Therefore, they're going to increase heart rate. Epinephrine, which is a neurotransmitter and also a hormone, also increases your heart rate. Body temperature, as body temperature increases in general, that causes chemical reactions to occur faster, and that increases your metabolic rate, and that increases heart rate as well. And if an increase in temperature increases heart rate, then you would expect that a decrease in body temperature would decrease heart rate. So everything here that increases heart rate is also going to increase cardiac output. And what decreases what decreases heart rate, like body temperature, is also going to decrease cardiac output. Electrolyte levels in the blood can also affect heart rate. This gets a little complicated, so I'm not going to go into the specifics of specific electrolytes such as sodium and potassium and calcium. However, just note that they can increase and decrease heart rate. All right, so those are the different factors that can affect heart rate and therefore can affect cardiac output. What about this other component, stroke volume? What might affect stroke volume and therefore affect cardiac output? So why am I showing you this image? I'm showing you this image to illustrate the effect of stretching something that's elastic on what happens when it contracts. As you know, if you take a rubber band or something that's elastic, the farther you stretch it, the harder it recoils. If I had a rubber band and I wanted to shoot it, I don't know, 2 feet, I wouldn't have to pull it back very far to launch it 2 feet. However, if I wanted to launch it across the room, I'd have to pull it back as far as I could before I let go of it in order for it to make it clear across the room. In other words, the more I stretch that rubber band, the harder it recoils. Well, believe it or not, your heart behaves in a similar manner. The greater the stretch of the cardiac muscle cells in the walls of your ventricles, the harder or the greater they will contract. So there was a physiologist named Starling, and he came up with the Starlings Law of the heart. And basically it said that the greater the degree of stretch of the cardiac cells of the ventricles, the more forcibly they will contract. Well, what causes, or what would cause the walls of the heart to stretch? Well, filling the ventricles with blood. That would cause the walls of the heart to stretch. So as more blood returns to the heart and stretches the walls of the harder the heart contracts. The ventricles specifically, the harder they contract. So in other words, the more blood returns to the heart, the more blood the ventricles move, right? In a very similar manner to stretching a rubber band. Prior to ventricular systole, so right before the ventricles contract, diastole ends. Remember, diastole is the resting phase. Systole is the contracting phase. The end of diastole is referred to as, well, the end of diastole. The volume of blood in the ventricles at the end of diastole is referred to as the end diastolic volume. So in other words, right before the ventricles contract at the end of diastole, the amount of blood in the ventricles is referred to as the end diastolic volume. It's the volume in the ventricles at the end of the relaxation phase, end diastolic volume. That is also referred to as the preload. Okay, you could think of it as like it's right when you pull back that rubber band right before you let go of it. It represents the stretch on the walls of the ventricles right before they contract. Well, like that rubber band, the greater the preload or the end diastolic volume, the more forcibly the ventricle will contract when systole begins. And the more forcibly it contracts, the more blood it moves, and therefore the greater the stroke volume. So in other words, the greater the preload, the greater the amount of blood in the ventricles, the greater the amount of blood the ventricle moves when it contracts, or the greater the stroke volume. So here we sort of have a visual, right? So here we have the heart, here we have blood moving from the atria into the ventricles. As that blood moves into the ventricles, it's going to cause the walls of the ventricles to stretch. And the stretch on the walls of the ventricles right before they contract is called the preload. The greater the amount of blood that is returning to the heart, which is called venous return, because the veins are returning blood to the heart, the greater the venous return, the greater the amount of blood that enters the ventricles, and therefore the greater the preload. The greater the preload, the greater the stroke volume when the ventricles contract. So as venous return increases, that is the amount of blood that returns to the heart, as it increases, the end diastolic volume or preload increases, and therefore the greater the stroke volume. Like that little guy we're launching through that slingshot, the greater the stretch, the greater the recoil. Similarly, the more blood that's in the ventricles before it contracts, the greater the stretch or preload, and when it contracts, the greater the stroke volume, the greater the amount of blood that is ejected. So, what are some of the things that can increase venous return, or the amount of blood that returns to the heart? Well, one of those activities that can increase venous return is exercise. And why is that? Well, many veins pass through the interior of your skeletal muscles. And as those skeletal muscles contract, they literally sort of milk or pump. Well, I don't want to say pump. Let's go back to milk. Milk blood through those veins back toward the heart. So when you start exercising and those skeletal muscles really start contracting hard, they start forcing more blood back to the heart. So exercise increases venous return. That's going to increase your preload, and that's going to increase stroke volume. Well, what's going to decrease venous return? Well, something like hemorrhage, or if there's a blockage in a vein, anything that interferes with blood returning to the heart is going to decrease preload and therefore decrease stroke volume. So the loss of blood or a blockage of blood returning to the heart is going to decrease preload and therefore decrease stroke volume, which is going to have a decrease on cardiac output. Contractility is another property that can affect stroke volume. And what do I mean by contractility? Well, contractility is the strength of a contraction at a constant preload. So I think you understand that the greater the stretch on the walls of the heart prior to contraction, the greater it's going to contract. Well, what if I could add something to the ventricles that would make them contract even harder? It would make them contract even harder without a further increase in their stretch, right? That would be contractility, where there are certain conditions, or in some cases substances, that increase contractility. That is, they increase the force at which the ventricles contract without further stretching on those ventricles. Substances like calcium channel agonists. So a drug or something that increases calcium channels, or increases the flow of calcium, I should say, through those calcium channels into cardiac muscle cells, will increase contractility. Well, how does that work? Why would an increase of calcium entering those cardiac muscle cells increase how hard those cardiac muscle cells contract? Well, remember that cardiac muscle cells get about 10 to 20% of their calcium from the extracellular fluid. So if there's an increased flow of calcium into the cytoplasm of the cardiac muscle cells, there's going to be further opening up of those binding sites for the myosin heads. And so if you have more myosin heads binding the actin filaments, you're going to get harder contraction by those cardiac muscle cells. So increasing the flow of calcium into cardiac muscle cells increases stroke volume. And indeed, for people who have weak hearts, there are drugs that increase the flow of calcium into those cardiac muscle cells to help increase the contractility of the heart. That's a common drug administered to patients who have heart disease or heart failure. Sympathetic stimulation of the wall of the cells of the ventricles also will increase the contractility. So epinephrine releases a neurotransmitter by the sympathetic nervous system. That'll cause those cardiac muscle cells to contract harder, mainly through opening calcium channels. Epinephrine, glucagon, thyroid hormones, all of those hormones will increase the contractility of the walls of the heart. Digitalis is a drug that increases the flow of calcium into cardiac muscle cells. All of these different compounds increase stroke volume by increasing, and increase contractility by increasing the flow of of calcium ions into the cardiac muscle cells. And contrary, calcium channel blockers decrease contractility. Some individuals have anxiety and will tend to have very hard hearts that beat rather vigorously, which just feeling that and hearing that itself can make anxiety worse. And so sometimes people with anxiety are treated with calcium channel blockers that block and reduce the amount of calcium that enters the cytoplasm, and therefore you get a decrease in the contraction. When I get to a stopping point, Emily, I will address that question. Okay, we're going to continue talking about stroke volume. So we talked about what could increase stroke volume. What about what might decrease stroke volume? What could decrease stroke volume is the resistance against which the ventricles have to pump that blood. So as blood flows through a blood vessel, wherever it encounters the walls of that blood vessel, there is friction, right? Think of dragging something across the ground or across the carpet, where that substance, that object that you're dragging is dragging upon the carpet or whatever, there is resistance there, which is called friction. Well, as the blood flows through the blood vessels, through the arteries, there is friction between the blood and the walls of the blood vessels. There is resistance to flow of that blood, and that is called peripheral resistance or the afterload. So this is the resistance against which the heart has to pump blood. In general, the greater the peripheral resistance or afterload, the greater the stroke volume. And I tried to show that with this arrow. It's like this is peripheral resistance is countering the flow of blood out of the heart. So the greater the peripheral resistance or afterload, the lower the stroke volume. Well, what can affect peripheral resistance? Well, one thing that can affect peripheral resistance is simply the size of the blood vessels. Vasodilation is an increase in the size of a blood vessel. When the smooth muscles of a blood vessel relax, the blood vessel gets bigger and there is less peripheral resistance. So vasodilation decreases peripheral resistance. Vasoconstriction is the opposite of vasodilation. This is when the blood vessels constrict. There is now a smaller pathway for the blood. There's more blood running into the walls of the blood vessel per unit of blood, and so that increases peripheral resistance. So vasodilation will tend to increase stroke volume, increasing cardiac output, and vasoconstriction will tend to decrease stroke volume, therefore decreasing cardiac output. So I have a quick question for you, and that is, why do people who regularly participate in aerobic exercise have lower resting heart rates? So assume you are aware that people who regularly run or swim or do aerobics will tend to have a lower resting heart rate than people who are more sedentary. When I say resting heart rate, it's like what you're doing now, right? You're not moving around very much. It's the rate at which your heart is beating now. People who regularly engage in aerobic exercise will tend to have lower resting heart rates than people who do not. Any idea why that is? Well, let me rephrase that. Why do athletes make better lovers? Well, the answer is they have bigger hearts, right? And the heart, your heart is related to, love and caring, right? So your heart's a muscle. And like any muscle that has to do more work, it can grow in size. And in actuality, it doesn't really grow that much in size due to aerobic exercise. But endurance training results in a heart that produces a greater stroke volume. So every time the heart contracts, it moves more blood. Now let's put that in the context of our equation for cardiac output. So let's say you have a non-athlete. Maybe if he or she was being chased by a lion, he might be able to maximize his cardiac output at 4 to 5 times the resting cardiac output, right? But that's as much as he or she could gather, right? 4 to 5 times when they're running as fast as they can from a lion, what they could were just sitting looking at TV. An athlete or someone who engages in aerobic exercise regularly, if they were chased by a lion, because they've been conditioning, their maximum cardiac output might be 7 times that of of their resting cardiac output, right? Well, how is that possible? Well, there's going to be changes not in the heart rate, but in changes of stroke volume. So recall our equation: cardiac output equals stroke volume times heart rate. Anyone who is at rest is going to have a cardiac output of about 5,250 milliliters per minute. It doesn't matter if you're an athlete or if you've never exercised a day in your life. When you are sitting at a table at rest, your tissues require the same amount of oxygen and therefore the same volume of blood, right? Regardless of your physical condition. Okay? So if you're that non-athlete or you don't do any kind of aerobic exercise, your heart can beat at 70 milliliters. I'm sorry, your stroke volume might be 70 milliliters per beat. And if your heart rate is 75 beats per minute, your cardiac output is going to be 5,250. However, if you are an athlete, maybe your stroke volume is 90 milliliters per beat. Well, if your stroke volume is 90 milliliters per beat and the necessary cardiac output is 5,250, your heart doesn't have to beat at the same rate as someone whose stroke volume is 70 milliliters per beat. So this athlete, when they are at rest, their heart only has to beat 58 beats a minute in order to deliver the same amount of blood per minute as the sedentary individual. That is why people who engage in regular aerobic activity will tend to have lower heart rates. Their stroke volume is higher, therefore their heart doesn't have to beat as many times per minute to deliver the same amount of blood as someone who is sedentary. Lastly, this figure from your book basically summarizes all of the different factors that can affect cardiac output. Notice that it illustrates that it's heart rate and stroke volume that affect cardiac output. So again, in order for you to understand all the different factors that can affect cardiac output and how they affect cardiac output, you have to know this formula, okay? Because anything that affects heart rate or stroke volume or both will affect cardiac output. Okay, I want to take a moment to answer any questions that you have. Let me see if there are any specific questions about cardiac output, and then I will address your question, Emily. Any questions whatsoever? Okay, so Emily had a question about beta blockers, and you've probably heard of a beta blocker before. So beta blockers are typically administered to people as an anti-anxiety drug. So I want to go back to, I'm not sharing my screen. Bear with me just a second. I want to share my screen. Okay, share the screen. All right, cool. Now I am sharing the screen. So I want to go back to this figure right here. Now, what I'm going to share with you is somewhat beyond the scope of this class. I mean, it is related to something you should know, which is the effect of epinephrine on and the sympathetic nervous system on the heart. But when we start talking about beta receptors and stuff, that's beyond the scope of this class. Well, so the situation is the sympathetic nervous system increases your heart rate and also increases how strong the contractions of your heart are. And that's typically what happens when someone has an anxiety. Their sympathetic nervous system activity is elevated. Well, the sympathetic nervous system releases the hormones epinephrine and norepinephrine, and they bind these receptors on the cardiac muscle cells called beta adrenergic receptors. When they bind those beta adrenergic receptors, it causes heart rate to increase and it causes the heart to contract harder. To reduce both heart rate and how hard the heart contracts in an attempt to decrease anxiety, some of these patients are administered what are called beta blockers. They bind to the receptors, but they don't cause the cardiac muscle cells to contract faster or harder. They're what are called antagonists. Sort of like imagine you having your key and you're getting ready to put the key into your the keyhole of your house, and someone comes up and jams their key into your keyhole. It doesn't allow them to open the door to your house, but because now they've blocked you, you can't open the door to your house. That's sort of how these antagonists work. So by binding the beta adrenergic receptors with these beta blockers, they prevent the epinephrine or norepinephrine from the sympathetic nervous system or the adrenal medulla from binding to them, and that decreases heart rate and decreases how hard the heart contracts. So that's why they're called beta blockers, because they block the beta adrenergic receptors. Okay, questions? You are most welcome. Okay, so we only have 3 minutes left, and that's probably not enough time for me to go over arteries, veins, and capillaries. In fact, I know it's not. So what I was afraid I may not get to this topic. So what I did was this morning I actually recorded a lecture. It's only 14 minutes, so it's not very long, that covers this topic. And you're going to find it's a lot of overlap with, not totally, but a lot of overlap with the presentation on blood vessels, or at least a portion of it, I should say, for lab. So it's a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. It's 13 slides here that I cover in about 14 minutes on a YouTube video that I emailed you the link to this morning. So I'm just going to let you have at that. It's pretty cut and dry information. I don't think it's going to be anything that you find particularly difficult to understand. But what I'll do is I'll open up the floor for questions on Monday about that topic. Also, I emailed you a learning activity. It's the same email, learning activity on cardiac output, allowing you to apply what I discussed today. And then we'll cover that and discuss that on Monday. And then we're going to go in to talk about blood pressure and then capillary exchange, and then we'll be done with the cardiovascular system. I also emailed you a learning activity covering covering blood pressure, not capillary exchange, covering blood pressure. And I just realized I wasn't sharing my screen with you, so let me do that really quickly to make sure everybody understands. So these slides here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. I put together a 14-minute presentation that I recorded on YouTube that I emailed you this morning, so you can take a look at that. And any questions you have, I'll address on Monday. Complete your learning activity on cardiac output. I'm then going to cover blood pressure. And I emailed you again learning activity on that, which you can then do subsequently. And the last topic will be capillary exchange. And then hopefully on Wednesday, I have time to address any questions you have on the cardiovascular system or even some of the previous chapters, so that you'll be well prepared for your exam on Wednesday. So, I'm sorry, your exam on Thursday and Friday, because it opens on Thursday at 8 a.m. It closes on Friday at midnight. So that's all I have, my friends. Have a great weekend, and I'll be staying for 10 minutes for anyone who might have any questions.